for that excellent presentation. And now it's my great pleasure to introduce our final speaker, Dr. Anup Katheria. So Dr. Anup Katheria is the director of the Neonatal Research Institute at Sharp Mary Birch Hospital for Women and Newborns. He is an adjunct associate professor of pediatrics at the University of California, San Diego, where he teaches POCUS and echocardiography for their trainees. He is a content expert for the International Liaison Committee on Resuscitation. Most of his work has been focused on delivery room interventions, including several multi-center, multi-international trials in umbilical cord management, including cord milking and intact cord resuscitation in term and preterm infants, and less invasive surfactant administration. He is a center principal investigator at Sharp Hospitals, the first stand-alone community hospital ever to join the Neonatal Research Network. He will be speaking to us on from delivery to transition, updated evidence-based practices for umbilical cord management. And before starting, Dr. Katheria, I would like to thank Dr. Manitoba for funding and supporting us today. And please, Dr. Katheria, thank you for joining us. We look forward to your presentation. Go ahead, please.
Yeah, no, thank you, Al, and thank you, Ayman, for inviting me. And great talks by both Nathan and George. So it's really great to see just everyone's work and a lot of sort of overlap in these sessions. So I'll try not to be sort of so redundant on some of the things that have already been discussed, because I think there's some great content there. And again, apologize for all those of you sitting on a 3-hour Zoom. I hope feel free to get up and take a break. I'm sure these things will be recorded as well, but I'll try to keep this, as focused as possible and really give you guys a good overview on where cord management strategies are, where we're heading. Just really quick, as far as disclosures, I have no financial disclosures, but obviously as a researcher, I get a lot of funding from various agencies. So I will be talking about a lot of grant-funded work. And just, I always show like a nice background slide. A lot of these are drawings by Satyan, who really just illustrate why we're even interested in delayed cord clamping or cord milking or all these other things. We're trying to understand how blood normally works, and then thinking about, well, what do we do when it doesn't go right? And that's really the focus of this talk, is the situations that are challenging. What we think about when things go right is that blood is designed at birth to move from the placenta to the baby, right? There's no reason why, if in utero the blood goes back and forth between the baby and the mom, why does it all of a sudden end up in the baby afterwards? And this has always been a challenge even in the animal models, because they haven't been able to sort of replicate this. But in the human, you have these 4 forces, these 4 things that are transferring blood from the placenta to the baby. On the top left, you see that a uterus that's squeezing on the placenta is critical for that placenta to be then squeezed down to have blood then moving from the umbilical vein into the infant. On the bottom left, we know that since the artery, it's backwards, right? Artery is blood from the baby to the placenta. As that starts to constrict or even spasm, that's going to then stop that blood flow going out of the infant into the placenta. And then on the top right, we know that breathing is so critical. You want to aerate the lung, decrease pulmonary vascular resistance, allowing blood to flow into those lungs that, again, come in from the placenta. And then lastly, we need good cardiac activity that propels blood from the umbilical venous circulation to the pulmonary circulation. So all these things happen, and now you get that nice pink healthy baby, term delivered by vaginal birth, right? Those are the babies that this happens, majority of the time in healthy pregnancies. Now, what we're interested, at least for the purposes of this talk, is what happens when it goes wrong. What happens now when you have an obstetrician or a midwife, where now all of a sudden this baby needs to come to you as soon as possible? So a preterm baby, a term non-vigorous baby, what do you do? And what happens to these mechanisms? So number one, we cut the cord more quickly, because we can't, at least right now, we're not all ventilating and resuscitating babies with their cords connected. So that gets shorter. And then these 4 forces now get altered. So on the top left, we have cesarean sections. We cut through the uterus, and now that placenta is not being squeezed properly. And we know that the more preterm the baby, the more likely they are to have a cesarean section. You look at your own data at your hospital, your 22, 23, 24 weekers are more likely to deliver by cesarean section. Your 38, 39, 40 weekers are more likely to have a vaginal birth. These are just for normal pregnancies. On the bottom left, we know that when you have a tight nuchal cord, it's not the nuchal cord that's squeezing on the trachea that's making the baby floppy. It's the fact that that thin-walled umbilical vein gets squeezed while that thick muscular artery remains open. So pinching the cord while it's wrapped around the neck allows blood to flow out of the artery, but no blood is coming in through the vein. So blood is essentially pouring out of the baby into those placentas. Then on the top right, we know that babies that have apnea, respiratory depression, or are very extremely preterm babies that have a lot of RDS and high pulmonary pressures, they're not able to increase pulmonary blood flow the way they normally would. So you don't get enough blood into the infant. And then lastly, in really severe cases where you have bradycardia or even asystole, it's unclear without that cardiac pump if you're going to be able to transfer blood into that umbilical venous circulation. So while we may be happy, oh, we have to get the baby right away to resuscitate them, we get a hypovolemic baby that's actually more difficult to resuscitate and oxygenate and sort of and transition properly. And so this is the problem we face right now. And this is most of us that are studying this area are trying to figure out. And now we know that babies who are non-vigorous, right, in all these sort of cohorts, the floppy baby, the baby that needs a lot of resuscitation, these babies are more likely, to have low APGAR scores and be more preterm, and they're more likely to have IVH and die. So delayed cord clamping is only selectively being applied to healthy babies. The sick babies are not getting this intervention. And we see this in every single guideline. So here in America, we have our obstetric body, ACOG, we have ILCOR, and George gave a nice overview of how ILCOR makes recommendations. In Europe, they have EAPM. In Canada, where many of you are listening on this call from, is SOGC, and then WHO for low middle income countries. They all say to do delayed cord clamping, which is great. But you look at these underlined words where if it's feasible, if they don't need resuscitation or positive pressure ventilation. So the fallout is if you don't think the baby looks healthy and great, don't do delayed cord clamping because the guidelines are telling you that this is only applicable to healthy babies. And so we need other options and we need more research to help us guide us to what to do for these babies who aren't vigorous or can't get delayed cord clamping. So that's the purpose of the majority of this talk. I'm sorry if you were looking on a talk about, well, why should we all do delayed cord clamping? Why is it possible? I can give you references in the Q&A. Hopefully, in 2025, most of us agree that babies should all get delayed cord clamping, but if not, we can talk more. The purpose of where I was going to go with this discussion is what do we do for those babies that we can't do delay on? We can try to ventilate them during delayed cord clamping, and that's for the first half of this talk. And then the second half, I wanted to talk about cord milking because is there still a place for it? And we'll talk about the pros and cons. I've been studying this for over 15 years now, and we can get into sort of the details about milking. Okay, so first off, and I apologize, I've done a few Zoom calls and these videos don't always play well when it's being streamed. So on my computer, it looks very smooth here, but I apologize if it's choppy for you. But here you see a 26-week baby who's being wrapped and stimulated, and then have some warm towels on, and then the nurse practitioner here is providing some CPAP. And again, the idea was that could we provide some of the initial steps of birth, which are CPAP, right? We heard that in the last few talks, and then allowing them to transition while they're on the cord. And the idea was that, well, surely if we keep a baby on the cord and provide the same initial steps, their lungs should aerate, they should do better, and this should be better than delayed cord clamping alone, right? Well, it didn't work. In fact, several trials, large randomized controlled trials, have looked at these outcomes of either IVH, composites of IVH and BPD, or even NEC and IVH, and they've not really shown a benefit in their primary outcome. Maybe some subgroups like less intubation, maybe some gender differences, but we had hoped we could see differences. And you could say, well, Anup, maybe these studies are too small. We need to do large meta-analysis. So in fact, we've done two. One is looking at these two studies here, combining them. And this is over 1,800 babies. If you combine these delayed cord clamping without support and delayed cord clamping with support. Outcomes of mortality, IVH, BPD, transfusions, no difference. In fact, if anything, slightly lower temperatures. And this I'll get into a little bit about maybe long delayed cord clamping may not be the best thing for the tiniest babies if they have low temperatures. And then there was also a individual sort of network meta-analysis done by one of the members of ILCOR. And we looked at all the different groups, whether it's physiological-based cord clamping, that George mentioned in his talk, cord milking, intact resuscitation. Now, all of these seem to be better than sort of immediate cord clamping alone in terms of the point estimates. But really, none of them have been significantly in terms of one mode is superior compared to early cord clamping and reducing these morbidities. So I think it's important when we think about these interventions that we still have room to improve on. So this gets into what are the challenges with intact cord resuscitation in preterm babies? Well, the biggest challenge is that their majority, as I mentioned earlier, delivered by cesarean section. So you have to deal with these babies who are coming out of the uterus that don't have labor oftentimes delivered by maternal reasons. They don't get the catecholamine surge. Their lungs are filled with fluid because they can't clear that fluid through the vaginal canal. And so it's more challenging to get them to start to breathe. On top of that, their effort in breathing is poor. I showed you that one video earlier, and in our trial that showed no difference between ventilation and not, we showed that majority of these babies need time to start to breathe. Only about 40% of these babies were breathing in the first 20 seconds. So many people would just have clamped the cord if they weren't getting CPAP. So it took time to get these babies to ventilate. The other side of it is that if we go very long, we have to make sure that when you go to a 23, 24-week C-section, I encourage you to look at that operative field. And if you look carefully compared to a term C-section, we often don't pay attention to this as neonatologists, but at preterm C-section, there's a lot more blood because you have these thick myometriums and huge blood sinuses. So as the OBs are cutting, it almost looks like the babies are having an abruption, but in fact, it's just the bleeding through the uterine edge walls. And the increased maternal blood loss is much higher in preterm C-sections than in term. And I didn't realize this, so we started looking at some of the safety data for deferred cord clamping. And one of the studies that looked at sort of multiples and deferred cord clamping versus singletons is showing this increased postpartum hemorrhage that if you take too long to deliver babies, as far as keeping them attached, you have to be careful that you're not seeing more hemorrhage in these mothers. And I think that's an important consideration when we go very long in the operative field. The other piece to think about is that how much time do we really need before most of the blood comes through the placenta? And we look at the original data, this is done by Alice Yao back in the late 60s, that looked at the blood left over in the placenta. So this is a backwards way of thinking of it. As the placenta drains, it gets lighter and smaller, and then you can infer how much blood ended up in the baby. And so part of this is looking at the residual blood volume left over in the placenta, that most of this happens in the first 90 to 120 seconds. So after you go past 2 minutes, you're not really seeing a huge sort of change in the amount of blood these babies are getting. So you must be doing it for other reasons if that's your intention. So the other piece to think about is that, is there benefit in babies going above 120 seconds that are preterm? And the answer is, when you look at postpartum hemorrhage increases in some of these babies with longer delays, you look at the lower temperatures in babies with 2 of the trials, and you look at the fact that most of the blood transfusion happens in the first 2 minutes of life, I'm not convinced yet. And I could be convinced by maybe more data coming out in the future or other people sort of having better experiences with this, but I'm worried that we might be causing more harm or maybe not seeing the benefits we'd hope to see by going much longer. Remember, just to show you some old references here, this is the old Neonatal Research Network data. For every 1 degree Celsius decrease in admission temperature in a baby, you increase the odds of late onset sepsis by 11% and the risk of death by 28%. And then moderate hyperthermia, we know that increases the risk of severe IVH and death in low birth weight infants. So again, I'm not saying that any of these trials showed higher adverse outcomes, but we didn't see the benefits that we saw that we should have seen by giving them deferred cord clamping compared to early cord clamping in some of these studies. So, just for this first part, just to think about longer duration, because you're going to hear more about this as, people are starting to look at the literature. we need to know that one is that it's longer duration is going to be more challenging for those of you that have tried to do this in your own units. Um, 4 or 5 minutes on the cord at a C-section is not easy to do. And we need to have good safety data on the mothers. We cannot forget about the mothers during this process of going longer and then their safety. And we need to ensure that the sickest infants can receive some time to transition on the cord, whether it's respiratory support or some gentle stimulation. And just thinking about what can we do, and this goes into the next part of what I wanted to talk about is the future. Maybe there's stuff we can do during deferred cord clamping to optimize ventilation and then move the baby where we're still not causing any maternal risk, but move the baby to a place where we can continue ongoing resuscitation. So I'm not going to be the one here telling you that we should complete all resuscitation on the cord and then clamp it when they're ready to go to the NICU. I think Nathan just gave a great talk too on all the different nuances that we have to think about ventilation. Imagine trying to do all those things during deferred cord clamping. We could see how difficult that could be. So I wanted to first share some of our own data, which show that, in fact, deferred cord clamping compared to something like cord milking had different oxygen saturations when we looked at our sub-study from our preterm cord milking trial. If you look at here in the solid line, these were babies that had cord milking, and the dotted lines were the babies that had deferred cord clamping in the first 10 minutes. And this red line, and you heard about this in the last few talks, so I'll sort of briefly mention it, was 80%. That's a good target for where we should be at 5 minutes. And you can see that 2/3 of the babies in the deferred cord clamping group are below that 80% mark. And that's something that maybe we can try to improve on. And then why do babies with deferred cord clamping have lower SATs? Well, in our trial that I did earlier, looking at CPAP on the cord versus not, we used room air. We thought at that point that was the right thing to do. But most of these babies took a long time. This is the solid line here. The red shows the babies that had CPAP. The blue line were just stimulation. But it didn't matter what you did. It took time for these babies, the majority of these babies, to start to breathe, or at least a minute, and in some cases, maybe even longer. Again, this slide was shown earlier, so I won't mention it, that again, 80% is a good early biomarker for having death or severe IVH. And we looked at our own cord clamping studies in San Diego and said, well, do we see the same thing? So if you look here, the solid line are the babies that did not get to saturations of 80%. And the dotted line are the babies that did well. And if you look at this, the solid line here, the babies got more mean airway pressure. That's shown over here. They got more oxygen. But ultimately, their outcomes were still the same, where if you did not achieve a SAT of 80%, by 5 minutes, you had more IVH, severe IVH, or even death. And I think the point here is that we gave these babies more oxygen. We actually got their SATs up within normal, but maybe too late. Maybe this period of early hypoxia is bad for these infants, and we need to rethink about what we're doing for resuscitation. And again, you heard most of this earlier, so I'm not going to belabor it. But this individual patient meta-analysis led by James Stratodopoulos demonstrated that, in fact, high oxygen, 100% as starting and titrating down compared to low levels of either room air or 30%, reduced in-hospital mortality. And so we're now seeing at least a first glimpse that maybe we need to sort of rethink our sort of idea of lower and going up on these babies. In addition, this nice study by Janneke Dekker looked at babies randomized to 100% compared to 30% oxygen and showed the same thing, that babies were breathing better, had a shorter duration of mass ventilation, better saturations at 5 minutes. And she even looked at measures of oxidative stress and showed, in fact, they were similar. So you weren't causing the damage that people were worried about because it was over such a short period of time. And I might be saying, okay, Anup, how does this fit in with cord clamping? To me, it's this part on the right that I was very interested in, which is they're breathing better. What does breathing do during deferred cord clamping? And so the best way to look at this is a human study that, again, the group in Leiden did, where they did ultrasounds of the liver during deferred cord clamping and looked at how the babies were breathing. So if you look at the ductus venosus and the hepatic vein, when the babies were having inspiration, you saw anterograde flow. So flow was going through the ductus venosus into the inferior vena cava, into the right atrium. You were giving preload to that heart during breathing. So breathing is essentially like sucking blood in through the liver, through that system, the portal system that the ductus venosus feeds in through the umbilical vein, and giving these babies additional volume. At least the flow is going that direction. And so inspiration is key. If you can enhance inspiration and breathing during deferred cord clamping, particularly in those tiny babies, can you have this benefit? This is where the idea of giving them more oxygen during deferred cord clamping and then our sort of study unfolded. And so the idea in this was, can we avoid the toxic effects of hyperoxia by essentially giving them the 100% that gets in, that some of it leaks out the mask, but some of that does get into the lung. But whatever gets absorbed into the bloodstream will be diluted by the placenta. And so Satyan, as you all may know, not only a great artist, but a great animal physiologist, looked at lambs where we gave them a short burst of oxygen, which is in the pink here. But then as soon as the cord was clamped, they got 30%. So you see this initial upswing, very similar, giving 100% after early cord clamping. But what happens with early cord clamping, if you continue to give them 100% oxygen, they continue to increase their pulmonary blood flow. So they're almost overshooting. And 30% is very similar here. But if you look at some of the other effects, such as hyperoxia in the blood, you don't get hyperoxia in the blood if you only do 100% while the cord is intact. It's only if you continue on that you get this overshoot. And for us as clinicians, what do we think about? We think about SATs. And the only group that had the oversaturations were the group that's continued on 100% after the cord is clamped. If you just give this short burst of 100%, you continue on 30% afterwards, you'll actually follow the NRP curves here. So this was the animal study trying to test our hypothesis. And then we did a human trial, which was randomizing babies to 100% during 90 seconds. Again, I came up with 90 seconds, not based on any prior data, but only based on my idea of too long on the cord might be too challenging. So the goal was 30 seconds of getting the baby wrapped up and stimulated, and then 1 minute of 100% oxygen on the cord. The other group got 1 minute of 30% oxygen on the cord. And then we wanted to look at the incidence of hypoxia, which was which babies could get at or above 80% by 5 minutes of life. And so this was the first real double-blind trial of cord clamping. While the babies were on the cord, the team did not know if they were getting 100 or 30. I mean, you could try to look at them and see if they looked more pink, but we all know it's hard to look at a pink 23, 24 weeker. But once the cord was clamped and cut, you move the baby over to the warmer, and then they were resuscitated on 30%, and they could titrate based on their sort of normal curves. So, and we stratified and did all that sort of fun stuff down there. Here's the consort. I won't spend too much time on this. I really just wanted to get you to most of the data. The good thing is, though, when you're providing both groups of CPAP and oxygen, it's really hard to get too many protocol violations. So most of the babies got the intended treatment. Our primary outcome was the percentage of babies that had a SAT of 80%. And you could see here that the majority of babies did in the high percent group, about 69% compared to 39%. Most of the data was driven by the large strata group, but we were probably more powered for that. But in the end, both groups sort of moved in the same direction. We looked at things like heart rate. We have these little neobeat monitors that we put on the chest and gives us the heart rate. So you could see that while they weren't statistically significant, you could see these wide error bars here due to lack of data. They trended to be higher in the high group and lower in the low group. Similarly, as you can see for saturations, which met the NRP targets, higher SATs, FiO2 and heart rate were pretty similar. We looked at how much resuscitation we're giving them, the mean airway pressure, as I showed you earlier, similar. We did some NIRS, I'll be honest, only about 35 babies got NIRS in the DR. Sort of challenging, as you know, if those of you who've done hemodynamics research in the delivery room, not straightforward, but didn't look like any sort of clear signal one way or the other. We also did this in the NICU, as long with continuous blood pressure monitoring. They were all pretty similar. So just to get to the data, which is what I really wanted to show you, when we looked at the babies in the two groups, again, primary outcome was significantly different. Time to get to SpO2 was shorter, 4 versus 6 minutes. No differences in years. The big one, I think, at least as a clinician, I was worried about was ROP. Was I seeing a difference? Did not look like there was a difference between high versus low. Death, no difference. BPD, interestingly, was lower, which I'll get into the next slide, is actually a good thing as far as some safety. I don't think this intervention on this, at least as trial data alone, is going to say, well, we should do 100% oxygen to reduce BPD. But we did see the signal. No differences in antioxidants, and sort of higher PaO2s in the umbilical artery, sort of similar in the vein, but wasn't significant, slightly lower IVH, or at least half as many, but there were low numbers there. All of these sort of little secondaries, again, show you that as far as pilot data, feasibility data, it's probably okay to do. Again, the reason I mentioned BPD is our paper was published, and shortly after this great paper, animal study by Graham, and I think George is on this study as well, looked at, well, if I give lambs 100% oxygen for 10 minutes, what happens to their lungs? And essentially, you cause a bunch of inflammation in these lungs. So you can see here that when you look at preterm lambs and you're comparing the control group to the group that sort of got 100% oxygen, a large amount of inflammation is occurring. Even when you look at some of the markers of oxidative stress and inflammatory markers, you're seeing them upregulated as well. And so this is concerning, right? We don't want to damage lungs by giving these babies 100% oxygen. My counter argument is we did it on the cord. We did it while the lungs were still semi-fluid filled. The babies are transitioning. Some of that's getting into the baby through the face mask, but these are all intubated lambs, so all of it's going into the lung, and they're getting mechanically ventilated. So I think these are the things we probably have to take, but it's important to have a word of caution. We have a nice editorial that just got published, I think 2 days ago, in response to this paper, but essentially it's a word of caution that we still need to do a trial to make sure the lungs are safe, and the babies are benefiting from this 100% oxygen and not being harmed. So these are some strengths and weaknesses, which I've already kind of alluded to. And then again, highlighting that we need to make sure while the lung oxidation measures are not measured, hopefully this is still safe for them. So really the wrap up for this first part, and then I want to get into a little bit about our future trial here in the next 20 or so minutes. 100% oxygen during delayed cord climbing does reduce some of these measures and does not increase the risk of adverse outcomes. And as you've heard earlier from the two talks, is that we are supporting higher use of oxygen. We didn't say how high, although you can see from that individual patient meta-analysis, they were as high as 100. This is on the cord, and it sort of fits with that, with the benefits of that placenta buffering it. But again, we like to do larger studies. So part of this is I'm hoping to do a larger study, but the challenge we have is how to do these studies properly, right? And so we're looking at only 90 seconds. The obstetricians really just have to make sure they don't clamp early, but the neonatologists have to give CPAP. And one thing we learned from the ABC3 trial that Ian Tapas ran is that there was a learning curve in their study for ABC3, that for every procedure they did physiological base cord clamping, they could achieve that benefit in their primary outcome. So if they had done more and had better success, maybe there would have been benefit. So, we're arguing that it might be the oxygen piece, but it also could be better education and better training in terms of doing this. So we don't want to mess that up. And so part of what we're trying to do is create a lot of simulation videos and teaching. So we're working with one of the experts, at least in the United States, on simulation, which is Lou Halamic at Stanford. But we also have the benefit of our previous speaker. Nathan's work has been great with a lot of the simulation work he's been doing and the videos. So we together made a video, and I urge you to, in this video, identify who Nathan is. But it's using that heart rate monitor, and it's a sim on how to use heart rate monitoring during intact cord resuscitation. So I will play that for you, and hopefully you can all identify who Nathan is in this clip. This scenario depicts the resuscitation of a neonate with an intact cord using the NeoBeat to monitor heart rate. Okay, you ready? And baby is out.
On the mark, lower in bed. And baby now. Applying Neobeat. Heart rate is between 60 and 100. Applying CPAP. Baby's not breathing, starting PPD. No color change. Take corrective steps. 60 seconds. No color change. Heart rate still between 60 and 100. Reduce mask pressure on the face. Okay. Heart rate increasing. Heart rate's over 100. 90 seconds.
So I thought it would be useful to sort of illustrate that. And this is an actual patient. I'll just show a brief clip here of this baby.
It's fine, it's not my phone. Go ahead. You do clamping time. We are clamped now. Yep. And we are double clamped. And we are cut. In fact, you can hand it to the nurse. Maybe over to the second lady.
That's
You can tell we have a lot of fun during these deliveries, but yeah, this is our little 26-weeker there. Little cute face. But anyway, the idea is to give you an idea of how we're hoping to improve this process through monitoring and sort of education. So hopefully more to come on that. I don't have any updates on sort of our grant at this point. And then for the last, let's see, 15 or so minutes, I just wanted to talk a little bit about cord milking, right? A pretty controversial practice. Many people are very much averse to this procedure. But I want to highlight a couple things. First is the difference between intact cord milking, which you're seeing over here on the left, where the cord is repeatedly compressed and milked 4 times or 3 to 4 times, depending on the study. And then over here on the right, you see this baby who's now been moved over to a warmer, and you have a long segment of cord that's being unraveled and then milked 1 time towards the infant. And so that's the sort of 2 methods. Now, when we talk about cord milking, I think most of the concern has been from this animal study that looked at sheep equivalent to around 26 weeks that were, ventilated, anesthetized. But before they ventilated the lamb and they were completely not breathing, when they milked the cord, essentially the blood went up and down during milking, and during delayed cord clamping, it stayed the same. And so they sort of had the concern is that, well, if we're doing this, this must be causing IVH in human babies that are preterm. And then subsequently after that, there were studies done looking at that. Well, if you ventilated the lambs, the fluctuations went away. And again, this is in an intubated model. And this was done by the group in Buffalo, led by Praveen Chandrasekaran. The same group in Australia also showed same outcomes, where you ventilated lambs, the fluctuations go away. And so this was always the premise, like, does milking cause IVH? And so, as many of you might have heard or known, we did a study looking at babies 23 to 32 weeks, at least that's the way the study was designed originally, to see whether or not we would see more severe IVH. And about 1/3 of the way into the study, we saw exactly that, where babies that were 23 to 27 weeks had nearly a 4-fold increase in severe IVH with milking compared to delayed cord clamping. The couple things though that we couldn't say in the paper, but I think it's important to know when we have more discussion, is that when you looked at mode of delivery, all of the harm that we saw with milking was at vaginal birth. If you looked at the groups in C-section, it was essentially similar between both of them. In other sort of subgroups, you look at the majority of babies that had severe IVH, as you would have expected, are the 23-weekers, right? If you looked at the babies 24, 25, 26, all the way out, that was really, it was slightly increased, but it wasn't as dramatic as those tinier babies. And then the last piece I wanted to mention was when you looked at histological chorioamnionitis, so inflammation in the placenta. If you had chorioamnionitis there, the red line are the babies that had cord milking. The blue lines are the babies with deferred cord clamping across every gestational age here on the x-axis. And on the y-axis is the probability of having severe IVH. So you could say if you were a 23-weeker with chorioamnionitis and you were milked, your probability of severe IVH was 65%. So pretty high. and it kind of went down to almost nothing by the time you're 30 weeks. So chorea doesn't really matter in these older gestational ages. But you took choreo away, and all of a sudden there's no real difference between the two groups. Now, again, this is histological chorioagnosis, but I wanted to put it all together for you in this nice cartoon that Satyan drew for me, looking at everything together. So you take the placenta, that's again surrounded by an intact uterus, that's squeezing on the uterus, providing a good placental transfusion, right? Which is what we wanted in that first slide for healthy babies. And now you're basically taking that cord and you're milking it. You're milking the artery and the vein because they're both sort of in there. And on the vein side, as you're milking the cord, you're increasing blood into the right atrium. But in that 23-week infant, the pressure on the right side of the heart is high. So it's going to shunt across the frame and go to the left side of the heart, right? So that might be okay because you're increasing preload. And those of you that are hemodynamic people will say, well, we're improving that left heart function. But the problem is that's a lot of additional blood for that left side of the heart, especially if it's not getting into the lung. And so you, at the same time, you're also increasing the pressure in the descending aorta because you're also milking the artery. And as you do these two things together and you increase blood flow to the carotid artery, right, because they both converge on that side. And now you have a situation, as I talked to you earlier, you have inflammation in the baby or even in the vessels that are surrounding the brain. You have babies that are extremely preterm, that have the most fragile germinal matrices, those 23 weekers, that any little fluctuation could cause them to rupture. And now you're milking the cord, well, you're going to see severe IVH. And so fortunately, we were able to see that signal, but it's important to understand the nuances there. Because when I look at sort of deferred cord clamping as being the most stable, it doesn't get around what that means when you're doing early cord clamping. And early cord clamping, well, for what we know from all the studies combined, doesn't really cause it doesn't protect you from severe IVH compared to milking. In fact, there's really no difference when you look at these point estimates for milking compared to early cord clamping. So remember, when you're thinking about milking, it's not in comparison to deferred cord clamping. That was our trial, but the trial was designed to see if milking was an alternative. But when you think about milking, think about it in regards to a baby where the only other choice is early cord clamping. And now you're not thinking the same way as far as increased severe IVH. Well, then you could say, well, what is the benefit of milking a cord in a tiny baby if there's no IVH, if I'm comparing it to early cord clamping? Well, we've done studies, and even though we didn't show any differences in IVH, we did show differences in terms of resuscitation. Babies who had cord milking, similarly, like I showed you to deferred cord clamping, had better SATs. They needed less oxygen in the delivery room. So all is not lost just because you have to milk the cord, but it's only in situations where you really can't do deferred cord clamping. And I think that's what people keep missing when they're looking at the evidence to date. And then what about the older kids? Well, babies above 28 weeks, now we can handle this extra blood, right? We have better cerebral blood flow, better autoregulation. These germinal matrices are not that friable. Choreo is not going to have an influence in those older gestational ages. But we needed to study that, so we looked at another 1,000 babies, 28 to 32 weeks, to make sure that IVH, low-grade IVH, high-grade IVH, 3, 4 were not different between groups. And sure enough, they were similar. When you look at severe IVH, the only babies that we saw some increases were in the deferred cord clamping group. So in fact, there doesn't seem to be any differences here when you look at deferred cord clamping versus milking. And then when you look at things like hemoglobin, in fact, at C-section, as you might expect, you might get a slight bump, but it wasn't statistically significant. But that makes more sense. You're not having that squeeze on the placenta. So the only group that might be beneficial to sort of do milking would be at a cesarean section when you can't do deferred cord clamping. So that's sort of our take home from the data in the bigger babies. It was designed to be a non-inferiority trial, but technically, if you look at these margins, we did cross 1%. We were very conservative, but really these point estimates are very narrow. This is 1% on either side for any of these outcomes, and they're pretty close. So I think we feel like milking is probably a safe alternative for sure in babies 28 to 32 weeks. It kind of supports where the current guidelines are right now. They're a little bit more ambiguous as far as, well, should you do it or not in a situation that you can't do deferred cord clamping, but I think this data is pretty supportive for it. And then the last piece to talk about here in the last few minutes is what about non-vigorous babies? So I had the fortune of working with George and his team at University of Alberta and several other centers that might be represented here to look at non-vigorous term and near-term babies. And we wanted to see if it was better than clamping the cord right away. And this was a cluster design. Again, I won't spend too much time on it because you heard a little bit from George and some of his studies that he's doing. Very similar design as him. And really, I just wanted to highlight that we saw benefits in terms of a number of secondary outcomes, such as resuscitation, hemoglobin levels, HIE. Our primary outcome, though, was we had hoped to reduce admission to the NICU, and that was not statistically different. It was lower, but we didn't meet significance when adjusting by center. We did some hemodynamic studies too, showing that they're better. I'm not going to read all these off to you, but it just gives you the idea of thinking about when you're giving extra blood to these babies who are term, near term, who might be more hypovolemic, right? We talked about the nuchal cords or other situations where they may be floppy at term. Seems like milking is probably not only safe, but it helps them with some of their hemodynamics, and as well as how they're doing in the delivery in terms of better saturations. And then we also followed them out to 2 years, did some ASQs that you can see here were identical across the board. When you look at the 5 domains of ASQ, when you looked at the number of babies with abnormal ASQs, again, they were pretty similar as well. 9 to 10% of babies had maybe some anomaly, or sorry, 4 to 10% across the board, but they were similar. Same thing with MCHAT. We wanted some measure of social emotional behavior to make sure those were not abnormal. And again, they were pretty identical. So the take home from that is that milking seems to have some short-term benefits. You might get cool less, you might need less resuscitation, which all sound like good things. And you don't seem to have any long-term adverse risks. We're not causing strokes in babies, or if they were bleeding out of the brain and we missed it, well, we probably would have seen that in some neurodevelopmental outcomes, especially when we had a large sample size as we did. And we did publish this last year, so feel free to review that. Now, taking all this sort of together, what does that mean as far as consensus statements? So George mentioned that ILCOR makes recommendations, right? They don't give you guidelines. The individual countries write their own guidelines. So we know that delayed cord clamping is being recommended for at least 60 seconds in preterm babies. And then in term and late preterm babies to remain non-vigorous, they do suggest intact cord milking in preference to early cord clamping. It's really only based on our one trial, so the certainty is low. We need more studies. And then as far as subgroups, I could have you read this text, but really what I would rather do is show you this sort of cartoon in the next slide, which is when you look at the different gestational ages under 28 weeks, 28 to 33 weeks, and above 34 weeks. What do we do for milking under 28 weeks? If they're vigorous, we don't milk the cord. We've shown that's harmful. If they are vigorous, you can do intact cord milking as a reasonable alternative. So what we say by this is probably babies that are delivered for maternal indication or some other reason where you don't feel like the baby is depressed, it's probably a good option. We don't have this bar. I didn't study non-vigorous babies that were flat, asphyxiated, etc., for a number of reasons. So we're waiting on recommendations for there. The only thing we can say is if they're above 34 weeks and non-vigorous, here's where you have the recommendation from the MINVI trial, and ILCOR supports it. So in your unit today, if you have a non-vigorous baby at 35 weeks, the recommendations are that you can milk the cord in preference to early cord clamping. Obviously, if you could do deferred cord clamping, you should do it. It's only when you can't do it that they have a recommendation for milking in preference to it. Lastly, I mentioned other studies that need to be replicated. So there's a study in India that I'm happy to be collaborating on with Zubair Agai. And this is looking at centers in India and the incidence of HI, which is much, much higher. And so we hope to have more data from this study early next year to see if in 3,300 babies does milking reduce HIE as well as improve long-term outcomes in these centers in India. Okay, so unanswered questions. We know that we have milking and delayed cord clamping, but we don't have which situations that early cord clamping could be replaced with something like intact cord resuscitation. And I think that's where we're sort of going next, which is we need to know what to do in situations with abruptions. These studies are not systematically including them. What do we do when we want to do intact cord resuscitation, but we can't set up equipment? These are areas that still need further work. And I guess if I was going to give you a flow chart on sort of how to manage these babies, this is a nice cartoon by my colleague, Jenny Koo. Really the only groups, and there probably are other ones too, like a high drops kid or a recipient twin to twin, but if you have a nuchal or the cord avulses, you don't have a choice. You have to do immediate cord clamping. If you have a nuchal and you could do a somersault maneuver where you flip the baby, that's one way, but sometimes you just can't. And you have to do immediate, and that's just how it is. But the majority of babies, we should be able to provide some placental transfusion to. For the term baby, we have the options of milking and deferred cord clamping. And for the preterm baby, you have the option above 28 weeks. If you can stimulate these babies and get them to perk up, I think most of them would be vigorous, but if you still don't think you can wait that long, you could consider cord milking in that group. Many of us, including myself, are trying to look at intact cord resuscitation, but those studies are not yet complete to say in a non-vigorous baby, ventilating them is better. I didn't have time to go through all of those trials, but really we're seeing the same thing where there's no clear evidence that we should be ventilating babies who are non-vigorous compared to just delayed cord clamping alone. So I definitely have to acknowledge all of our wonderful collaborators across my two trials, and then also want to thank my NRN co-investigators for helping us with our upcoming doxy trial. So thank you very much.
Thanks a lot, Anup, and really I do appreciate the intensive review. So I would just, I know that there is like a very good feedback with like intact cord milking for with cut cord milking for extreme preterm babies. Has there been any randomization of cut cord milking versus in extreme preterm in a randomized control fashion?
Yeah, so Halifax did a pilot, which was great. It was a 50 baby pilot, 25 in each arm, just showing that it was feasible. It wasn't really powered for other outcomes. So I think they're hoping still, Walida Nagar is the PI for that. So they're hoping to get a larger study up and going. And then there's a study in China that's almost completed of 1,600 babies. And yeah, I wish I had more time to talk about cut cord milking, but they're going to compare cut cord milking versus intact cord milking versus delayed cord clamping. And it's in 1,600 babies. So, like around 700 in each arm, or 600 in each arm. So that's a non-inferiority study. They're hoping to demonstrate whether those are interchangeable.
Yeah. And seeing the new beat is a great technology that hopefully to see it soon. But in general, with absence of such monitors, do you believe that we should be monitoring the heart rate during applying delayed cord clamping?
Yeah, I think it's a good question. I mean, because one of the downsides of monitoring is it sometimes will scare you, right? So you put the neobeat on and the heart rate is 60, like, oh no, I have to clamp. And then you have to think, okay, wait a minute, this baby is still transitioning from the mother. We don't ever get heart rates at 0 seconds. And most babies, we have to move them over and then start listening. So you need to give the baby some time to sort of transition and do interventions. The reason I like the heartbeat, I just gave a talk on this earlier this morning, is I always worry about too much pressure with the face mask during intact cord resuscitation, actually during in general resuscitation. And so heart rate, that helps you sort of guide if you're doing the resuscitation properly, if you need to decrease mass pressure, do some other things to adjust these babies. 100% oxygen, I think, gives you a nice buffer, because I think the babies, their heart rates come up very nicely, as you saw in this slide. But it's a good gauge to make sure the baby's going in the right direction. So I like monitoring. I think it's helpful. We also have that PD cap, the color change, which we talk about if you're getting gas exchange. So those are two monitors that I like for intact cord resuscitation.
This was my second question. I noticed that you are using the capnography, the colorographic capnography.
Yeah.
Is it the usual one that you are applying during use of like TPs or any form of PPV device?
Yeah, TPs, and even before we used to use TPs, I listened to Nathan's Q&A. I think I agree. Using self-inflating bags is very very challenging, and I think, but even then, we used to use it with the PD caps as well. So I think it still tells you whether the lung is being fully aerated, and we use that as a marker that the baby's transitioning well.
Yeah. So one of our neonatologists, Dr. Faruqi, asking you, your work on physiological-based cord clamping suggests that waiting for cardiorespiratory stability is more important than a strict timer. How do you propose we train delivery teams to shift their focus from the clock to the baby's actual respiratory effort during the critical first minute?
Yeah, well, I will say I wasn't saying you should So here's my thing with physiological base cord clamping. I think it's great conceptually. Focus on the baby. If the baby's breathing, you probably are making good direction. But there was a trial or was a study out of Turkey that said, okay, we'll do physiological base cord clamping and time-based cord clamping. And you know what they found was that the babies in the time-based cord clamping had better hemoglobin and sort of transitioned better. And do you know why? Because the babies in the physiological base cord clamping had their cord clamped as soon as the baby cried. Well, guess what happens in a term baby, healthy, that's delivered? When do you think they start crying?
Immediately.
Like 10, 15 seconds. So they would clamp the cord saying that's physiological based cord clamping. I think we need some time is my point. You don't want to clamp the cord before a minute. I don't care how good the baby looks. You need to get to at least a minute. If you want to focus on giving the sicker babies more time, that's great. That's what physiological base cord clamping should be. But many people, they just start thinking, oh, okay, I'm going to look at the baby, not the timer. And when the baby looks great, I'll clamp it. I think you still miss some of the nuance there, which is we need time for blood to get into the baby. And then if you can go longer, great. But I'll be honest. I mean, I don't know if Canada is much different than the US when it comes to cord clamping, but many OBs are not going to sit there and let you wait as long as you want for those babies, even in a research protocol. So if in your unit they're willing to wait 4 or 5 minutes because the baby still needs more time, then great, do it. But I personally think we are still a long way away from that. And I want to see better evidence that it's really doing a good job, because once enough blood is in that baby and I can move that baby to a warmer and do a proper resuscitation with the TPs and titrate my stats. We just talked about, Nathan mentioned the OptiStart study. You know, George is looking different FiO2s. Why can't we still do good resuscitation, but get the baby well transitioned on the cord? I don't think we need to do everything together. And that's my struggle with the term physiological base cord clamping and how we don't really know how we're applying it. And I think that's what I'm quite, I don't think we need some time approach, but still something to be able to allow those sicker kids to stay on the cord. I guess that's my answer. It's not a good answer, but it's the best I can do right now.
Yeah, thank you. So Dr. Iyad Muzaffar is asking you, how do you use new beat in the operating room and keep it sterile, field? You mean?
Yes, that's a great question. You know, the people from NeoBeat were trying to create a true sterile product that you can actually between uses, but they couldn't get to the degree of pure sterility in terms of even autoclaving and the plastic and all that. So what they do is you can get it to clean grade, where with enough, you know, soaking in alcohol, et cetera, you're killing like 99.9%, but it's not truly sterile. So what we do is intact cord resuscitation. We say everything at the nipple line is sterile. Everything up here, is clean. So it's not going to be sterile, it's going to be clean. So the obstetrician should not be touching the chest. You can touch the belly, you can touch the legs. Not that they need to touch the baby that much, but they can. And we wrap the baby up, and once we're ventilating the baby at the head level, there's no reason to touch anything else where we would contaminate their field. So the NeoBeat stays in that little plastic poncho that we have and is away from the OB's hands, which would have contaminated the field. And this has worked. I've been doing this. I do the NeoBeat clinically outside of my study. We provide CPAP to babies in my unit that are not even in the trial while they're on the cord, and it seemed to have been working fine. The same way the mask and the TPs, they're not sterile either. So we're putting all this non-sterile equipment on the baby's face and chest, but that's where the OBs are not supposed to touch the baby. And that's our communication with them, like our line in the sand for what should be touched and not.
Yeah. So I could see in the information you mentioned that the babies who received the extreme prems, who received cord milking, were different between the spontaneous vaginal delivery versus cesarean section. How do you explain this? Do you believe that they are getting larger amount of blood?
Absolutely. That's exactly what I can't prove it, other than some of these smaller hemoglobin differences. When you look at the hemoglobins in the vaginal group, they're similar but higher. And the C-section, there's a bump in only the milked group. And I do think that uterine squeeze, and you look at some of the older studies in the late 80s and 90s that looked at mode of delivery, they are lower when you deliver by cesarean section. You don't get good hemoglobin bumps as you do in a vaginal delivered baby. And I think, I see this anecdotally all the time, even in our unit. You know, if I get a 25-weeker vaginal delivered, they actually do really well in terms of their hemoglobin levels at 12 hours of life. I don't see the same thing in our C-section infants, and that's fine. That's just the reality of mode of delivery, and we have to sort of deal with that.
Yeah. So one of our fellows, Dr. Vikram Katodia, is asking you, with physiological cord clamping, chances of hypothermia wouldn't go up?
Well, if you keep the baby on the cord longer, the chances of hypothermia probably do go up. I mean, look, we check temperatures at 5 minutes of life in my unit. So the 5-minute APGAR, they check an axillary temperature. We use chemical warmers underneath the baby. We use a poncho. We wrap them in plastic. And our room that we are in is separate than the operating room. But I will tell you, when I first introduced this in my unit in 2013, the babies were cold. They were 35 at 5 minutes, 35 degrees, just for 60 seconds of deferred cord clamping. You have to try so hard to warm these babies. Now, I know some units that have said to me, Anup, we can raise the temperature in our operating room, so you should have no problems with hypothermia. And I can't get my obstetricians to raise the temperature in the operating room. I don't know, is in your unit, is your operating room heated when you have a 23-weeker?
It is. We are trying as well but it is always difficult for the obstetricians who are actually having like multiple gowns to raise the temperature as much as we expect.
Yeah, and so I know people that have managed. They've given the OBs like ice packs to wear and things, but I don't know. I wish we could just raise the temperature, and then this would be less of a problem. So it's a great point, and it's something we struggle with.
Yeah. Is there any rule for using near-infrared spectroscopy directly on the umbilical cord or on the placenta itself to know like that maybe the flow that's going to the baby stopped or not yet?
Yeah, there's been 2 studies, one out of Poland, and then another one that the group in Buffalo did, where they didn't do NIRS, but they put the pulse ox on the cord and try to look at the pulsation, and the sats read very low, right? Because you're looking at fetal venous sats, so they're like in the 40% range. So it doesn't help you with oxygenation, but as the Doppler waveform like starts to go lower, you can assume that the blood flow is going down. So maybe you could clamp. And I don't know if you some of the midwife literature, they talk about this wait for white. They just keep the baby connected until the cord gets white. But again, I don't think we have that kind of time to wait that long. But you can use like the cord flow to say when you stop if you have the time to wait, 5-6 minutes in some of these cases.
Yeah. So really lots of great discussion, and I'm so actually one of the people who are very fond of your work. So together with Satyan and the whole group. So I wish you all the best, and we are really very happy to have you here today. So just on behalf of the organizing team, we thank all the speakers, Dr. George Smolzer, Dr. Nathan Sangren, and Dr. Anup Katheria. And we also thank all the participants for joining us today. We hope the discussions and the insights shared today will translate into meaningful improvement in care for our smallest patients. Thank you again, Anup, and thanks to all the attendees, and we look forward to welcoming you again to our future webinars. Thank you.
Thank you so much.
Thank you. Take care.